I have a particular fondness for this topic because I have been working in the addiction field for about 40 years as a registered nurse, certified in addictions, and I have been using buprenorphine with our patients for probably about 8 years now, but more significantly within the last 16 months when our medical director took the ASAM course and we began using it with our medical director on site with our patients here. So in the program I work with. So I'm very, very happy with the outcomes that I see with this particular medication, and very proud to be able to present this information to you today, looking at a wonderful study that was done to bring research and good information into practice, utilizing the Clinical Trial Network, and finding some information for us about how to use this medication in a short-term withdrawal from patients addicted to opiates, and comparing that to a medication that we've known for a long time, Clonidine, that we've used in the treatment of opiate dependence as well. So this is a wonderful opportunity for us to talk about this medication, utilizing it in this way, but also to know that there is so much more to know about buprenorphine and how it can be utilized in the treatment of opiate dependency, that this is really just a small aspect of its care, but a very, very important and vital one. And I'd like to share my...
can you click that little, do you see the sign in the middle of your screen where we can turn it over to you so that we can see your slides?
Let's see.
Did you get that? Is there a...
I didn't get a... Are you not seeing mine?
Just a second here.
I have them up on mine, so I...
Okay, I just want to be sure that I see them. I'm not seeing them. Can somebody just send a chat or a quick question to let me know if you're seeing these? No slides, yeah. I'm going to, okay, there we go. We're all set now, thank you.
Okay, I saw the little message, I'm sorry.
Oh, that's okay, we're all set.
Okay, great, thanks. So the people that were involved in this blending initiative are NIDA and SAMHSA. And as you see in the slide, a blend, according to Webster's dictionary, means to combine or integrate and to produce a harmonious effect. That is truly what happened in this endeavor, and it is a work that was done utilizing a lot of people very, very interested in this topic and very committed to finding good treatment resources for patients addicted to opiates. So the initiative was developed in 2001 by NIDA and SAMHSA, and it was utilized to try to meld science into practice. And the purpose always is to improve addiction treatment. Blending initiatives use researchers who look at information and then develop that into practice and give us the best information we can to utilize in our treatment programs and with our patients. And it is the dissemination of this information throughout the country that is really important too. As important for us here in I'm speaking to you from Bismarck, North Dakota, to all of you that are out there in different parts of the United States dealing with the same issues. These are the team members that were responsible for this particular initiative. You can see they come from a wide range of backgrounds and across the United States. The objectives for this training today are to describe opioid withdrawal and the role of medical interventions to use during withdrawal. We're going to understand the results of new research that's been done on one strategy to help patients withdraw from opiates using the medication buprenorphine. And also we're going to define the procedures that we use for using this medication in conducting a 13-day opioid taper utilizing this medication. So who are the participants in this endeavor? SAMHSA and CSAT. Their mission, of course, is to improve the lives of people that are suffering from addiction and to reduce the costs of health care and social costs to our communities and to our nation. This is a very, very devastating illness, and it affects families, employers, and everyone in a community. CSAT's initiatives and programs are based on research and the general consensus of experts who have worked in the addiction field, but mostly for individuals in treatment and recovery work. And we find that the best efforts that we have work in community-based programs that are coordinated to provide comprehensive services, for the patients that we're serving. And because no single treatment approach is effective for all patients, and if you've worked in this field for any length of time, you know that to be true. That there has to be a mix of available services and tools and modalities that we can offer people, because although the disease is alike in every person who suffers from it, their particular needs and individual concerns are going to be our individual needs and concerns as well. And we want to enhance treatment and enhance the recovery efforts that people are making. The ATTC network, who supports this presentation today and many other wonderful entry into practice and utilizing information based on these research and clinical trial networks, are disseminated through the ATTC network. I'm in the Prairie Lands network, as Chris said, and many of you represented from across the United States. NIDA has a couple of crucial missions as well. They have strategic support to conduct research across a broad range of disciplines, and many people who have an interest in drug abuse and in addiction have a voice in offering information and research based on their concerns and specifics in looking at addiction. And they also want to ensure that we have a rapid and effective dissemination of this information so that the research is there and we know more and more, but how does this help us in treatment of addiction? So a clinical trial network is NIDA's biggest initiative to get the research and blend it into clinical practice and bring this out to us. There is a network of 16 university-based regional research training centers that are involving community treatment programs in 23 states. I think there's probably more now, but 240 treatment programs at the time that this was developed, and that are very concerned and involved in the training. So the regional center is at the eye of the hurricane here, and then all of these community programs who participate in different types of research projects report to that research and training center. So we're going to look at the medications in this trial and talk a bit about those and discuss the differences between them, and then look at the research that was done. We're looking at a partial versus a full opioid agonist and antagonist. And to understand the process, we look at what the action of buprenorphine is in the body and how this affects people who have been utilizing opiates. So buprenorphine is a partial agonist, and this slide here looks at what a full agonist means is the full agonists are medications such as methadone, which is also used, of course, for the treatment of opiate dependence. A partial agonist, buprenorphine, has an effect on the receptor sites in the body, but has a ceiling effect, which we'll discuss. And then the antagonist, which is naloxone, we'll discuss that further as well. But we'll look at the different effects and how this medication works, and why buprenorphine is effective in the treatment of opiate dependence. Buprenorphine has a very high affinity for the opioid receptors in the body. it goes into the receptor, and because it has this particular affinity, it is more attracted to that receptor site. It goes in, it stays on the receptor longer, and it moves the other other opiates that are trying to get on that receptor off. I've heard it discussed and described very often as kind of the bully, and that once it's on the receptor site, that's where it stays. So if you're trying to use another opioid, buprenorphine stays on that receptor site and doesn't allow the effect of the other opioid ingested at the same time. The medication buprenorphine is this partial agonist, and it has the effects of a typical opioid agonist, but at lower doses of medication. And this also produces a ceiling effect at higher doses, so that even as you're increasing the dose of buprenorphine, you don't get an effect, the physical effects of the usual agonists. And it binds very strongly to that receptor site, and it is longer acting. It is a very safe and effective therapy for the treatment of opioid maintenance and for detoxification in adults. It's slow to dissociate from the receptor site, so that effects last even if you're dosing on one daily dose, or even if a dose is missed. There are reduced effects because there is prolonged use and this slow dissociation off the receptor site. The FDA actually approved the use with opiate-dependent patients 16 and older. We're going to look at how this is formulated. Buprenorphine is currently marketed for opioid treatment under the trade names Subutex and Suboxone, which is a combination of buprenorphine and naloxone. So it's a combination of the partial agonist and the antagonist, as we'll describe here. There's been over 25 years of research about this medication and the use of opioid dependence, and over 5,000 patients were exposed during the initial clinical trials of this medication, and it has been proven safe and effective for treatment. The clinical trials with opiate-dependent adults that have established the effectiveness of buprenorphine for the treatment of heroin addiction were used in comparison to a placebo, which contains, of course, no drug, methadone and LAAM, which is no longer available or utilized. The research outcomes showed that buprenorphine was as effective as moderate doses of methadone, and that it was as effective as moderate doses of LAAM, and that buprenorphine's partial agonist effects makes it mildly reinforcing, which encourages medication compliance. And this is what I have found most common in our patients, is that this medication helps people to feel normal. If there is a word that our patients use, or I've heard other professionals describe with this medication, is that it's this the immediacy of the medication provides for an ability for patients using it to just feel comfortable, and it allows for better engagement into the treatment process as well. After a year of buprenorphine plus counseling, 75% of patients were retained in treatment, compared to 0% of the patients that were using a placebo plus counseling condition. So we can see that there is significant evidence to support the appropriate use of this. There are two formulations of buprenorphine, buprenorphine with naloxone and buprenorphine without the naloxone. The advantages of using buprenorphine with the antagonist in it is that it discourages IV use, and it is much as a diversion of these medications. And as we all know, patients who have addiction issues, this is one of the major things that we deal with is medication compliance and utilizing medication appropriately, and not diverting it for other uses, or diversion to others, or selling, or using the medications for purposes other than what it was intended. So the reason that the naloxone was developed and with the buprenorphine is that it when it's presented into the body, the tablets are utilized sublingually, and you get far more of the buprenorphine utilized that way sublingually. It's absorbed better into the body, and the naloxone that's combined with it is only utilized in very small amounts. So but if it was diverted and attempted to be injected, you would get much more of the antagonist, the naloxone, than you would get of the effect of buprenorphine. So it has been effective in that way in preventing diversion and preventing IV use or conversion from sublingual use into injected use. Using buprenorphine in regards to cost effectiveness, but when you look at that, medication costs are only really one factor in this. Certainly, buprenorphine is more expensive than utilizing other medications that have been available for a longer period of time. The costs are greater than they are for methadone, for instance, or as we'll talk about today in the utilization of Clonidine, which is, of course, significantly cheaper. And that is a major issue for some patients. There are insurance companies, of course, that cover the cost of this, granting grant funds available, and Medicare, Medicaid covering the cost of those medications depending on, on the patient and the site and the practices of each individual state agency. There have been some studies in young adults, and we have a initiative and a blending of information specifically for that population, that research that was done. It's a small study, and more research is being done for that particular young adult population. But there has been demonstrated cost effectiveness, though, with adult populations with utilizing several other indicators. When you look at the amount of heroin-free days or opiate-free days using buprenorphine versus methadone, there is a significant cost comparison there too. And there is no statistical significance between cost effectiveness for buprenorphine and methadone. Treatment with buprenorphine and naloxone was associated with a reduction of opiate utilization and the cost in the first year of follow-up. And the cost effectiveness of this, I think that's often the major issue with looking at buprenorphine is that. But when you look at the benefits and how specifically this medication really works very well for some people, it is, you look at the lifestyle that goes along with opiate dependence, the cost of this medication is significantly less, really, when you're looking at the lifestyle that's involved in opiate dependence. And a study in Australia also found that buprenorphine lowered the crime costs, and there was a higher quality of life adjustment that surrounded patients in recovery with the utilization of buprenorphine compared to methadone or other lifestyle-related issues. Each tablet of buprenorphine and naloxone is developed in a 4-to-1 ratio. So an 8 milligram tablet of buprenorphine or Suboxone contains 2 milligrams of naloxone, and each 2 milligram tablet contains 0.5 milligrams of naloxone. The ratio was deemed optimal in the clinical studies that were done. It preserves the buprenorphine's therapeutic effects when it's taken as intended sublingually, and there's sufficient dysphoric effects occur if it's injected by physically dependent persons, and that has worked to discourage abuse in that way. Buprenorphine and naloxone have different sublingual to injection potency profiles that are optimal in the use of a combination product. You can look at, with buprenorphine, sublingually you get 40 to 60% of the medication taken that way and in a potency of 2-to-1, and naloxone 10% or less when you take it bioavailability, when you take it sublingually, and 15-to-1 when it's injected. basic pharmacology and pharmacokinetics and efficacy is the same as buprenorphine alone. And the partial opiate agonist, the ceiling effect, is there at even higher doses. So you can increase the dose of the buprenorphine and reach that ceiling effect, and you can relieve withdrawal symptoms but not experience the opiate type effects of those drugs, of a full agonist. And it blocks the effects of the other agonists, as I mentioned earlier, and it binds really strongly to that opioid receptor, and it is longer acting. You look at our use of Clonidine and look at this particular medication and why it is utilized, and some of the positives with this as well, is that it is not a scheduled medication. I mean, there's no special license required to utilize Clonidine for the treatment of opioid dependence. Any physician or nurse practitioner or physician's assistant who is licensed to utilize this medication can do so for the treatment of opioid dependence. It is an off-label use of Clonidine, but it has been studied and standardized through many years of use for the treatment of opioid withdrawal. With buprenorphine, of course, physicians prescribing this medication have to have a special course of study and a special adapter to their DEA license in order to utilize this medication. Clonidine can be used in inpatient or outpatient settings. It partially suppresses the symptoms of opioid withdrawal, such as the nausea, vomiting, sweating, and diarrhea. However, not real effective as buprenorphine is, as we'll see, in alleviating some of the subjective effects of opioid withdrawal, like the body aches and the abdominal cramps and craving, and the kind of symptoms that plague our patients as they're coming off opioids. The contraindications for use of Clonidine, though, include pregnancy. It's not safe for use in pregnancy, liver damage, a history of auditory hallucinations or delirium, a systolic blood pressure that's less than 90, and a recent myocardial infarction would be a contraindication for it as well. Any chronic renal failure or any history of hypertension, hypotension, fainting, or dizziness on rising would also contraindicate its use. Medically assisted withdrawal is a period, when you look at withdrawal as being, many times the reason that patients who are dependent on opioids fail to seek treatment is because they are so uncomfortable or the symptoms are so painful for them that the thought of having to go through withdrawal in order to achieve recovery keeps people away from treatment services and support through withdrawal. Knowing that there is this medication and other approaches available to them, I think is really helpful in that the word is out there about buprenorphine and how it works, and that it's become more attractive for people to seek services knowing that their withdrawal can be successfully managed with this medication, this approach to treating the early symptoms. But a period during which somebody who is addicted to a drug or other addictive substance stops taking it causes that person to experience these painful and very uncomfortable symptoms. Or a person takes a similar substance in order to avoid experiencing the effects of those withdrawal symptoms. The intensity of withdrawal, of course, is going to vary with the level and chronicity of use of a patient. And the cessation of opioids causes a rebound in function altered by chronic use. So the duration of the withdrawal is also going to be dependent on the half-life of the drug used that the patient or client was using. But the peak of withdrawal usually occurs within 36 to 72 hours after the last dose, and acute symptoms are beginning to subside over a period of 3 to 7 days. But there are protracted symptoms, as we know, with opioid addicted patients that are quite protracted and can linger for weeks or even months after people stop using opioids. Medically assisted withdrawal then relieves withdrawal symptoms while patients are adjusting to a drug-free state. Medication-assisted withdrawal management can occur in an inpatient or an outpatient setting. and it typically occurs under the care of a physician or a medical provider. It serves as a precursor to behavioral treatment because it is designed to treat the acute physiological effects of stopping drug use. This provides us with a wonderful opportunity to help patients into the behavioral aspects of treatment, that just using medication-assisted withdrawal is not enough to help people maintain abstinence and maintain a recovery effort, as we'll talk about in more length as we go along too. So the principles of medically assisted withdrawal are that we complete an initial assessment and look at the factors of medical and psychiatric history, at alcohol and drug history, and prior withdrawal experiences to determine the potential for withdrawal. And we'll also look at pharmacological management of withdrawal. What is the best option for the patient that we're seeing? And how do we utilize ancillary medications, not just the medication specifically for the treatment of withdrawal, but what other medications can be used for the complaints that patients have as they are going through the detoxification or withdrawal process. And what provision can we make for the psychological support that's so necessary for these patients, that we find that it isn't just the medication that will provide the best approach to treatment of withdrawal and of opioid dependence. Little data has really been generated for short-term use of buprenorphine and naloxone for medically assisted opioid withdrawal, and that was the function of this particular study, was to look at that. Look at what the advantages are going to be for using a short-term or shorter-term use of this medication to help people through the withdrawal process. Studies are needed to determine the strategies for assisting with withdrawal, however. The diversity of clinics that are utilized in the clinical trial network really provides an unparalleled opportunity to look at and to conduct such a clinical endeavor, because patients who are involved in the clinical trial network came from a lot of different backgrounds, a lot of different areas, as we'll see. There were 2 buprenorphine naloxone protocols studied here in this particular study we're going to discuss today. It was a study of buprenorphine and naloxone versus Clonidine in short-term inpatient opiate detoxification, and the other study was conducted in outpatient programs, also looking at naloxone, buprenorphine and naloxone versus Clonidine, also using the short-term withdrawal, and it was initiated in 8 regional nodes and utilizing 12 different treatment providers. And this is where they came from. In the Great Lakes region, in the Ohio Valley region, Long Island, Florida, and in the Pacific region, and also in Oregon, in Southern California, and in New York and Delaware, and again up in the Ohio Valley. So you can see there was a these sites gave an unprecedented look at the utilization of this medication in different populations across the country. So there were 2 open-label randomized clinical trials done that compared the buprenorphine and Clonidine in a short-term 2-week or 13-day detoxification process, both in residential or outpatient settings. There were 6 inpatient sites and 6 outpatient sites. In the 6 inpatient sites, 2 were therapeutic communities, 1 was a freestanding chemical dependency hospital. There were 2 detoxification units with integrated addiction and mental health services, and 1 long-term residential program. The usual approach in their care prior to this buprenorphine initiation was 50% of their patients were treated with methadone, 50% with Clonidine. In the outpatient study, there were 4 opioid treatment programs, 1 HMO, and 1 community mental health center. Their usual care approaches had been methadone utilized in the opiate treatment programs in the area and clonidine utilized in the HMO. The study was developed in this way. The patients were I can't think of the word, but they were recruited. That's the word I wanted. They obtained informed consent from the patients. They did pre-screening and did baseline assessments on the patients. They were randomized, and then there were 240 participants that were utilized in the buprenorphine naloxone, and 120 utilizing the clonidine 13-day detoxification. And the idea was to follow up at 1 month, 3 months, and at 6 months. It was hypothesized that buprenorphine naloxone detoxification compared to clonidine will be associated with a better treatment response, and that a treatment responder is anyone who completed the 13-day detoxification program and that their last urine specimen was negative for opioids. That was the efficacy endpoint in the study. So the findings of this study included, in the study you can see that there were a greater ratio of male to female. The race is broken down here as well as the age of the persons in the study, the percent that were employed, and their education is lined out here, and the number of years that they had been using heroin prior to the onset of the study. These are the demographics of the inpatients. I just wanted to mention too that as Chris had said at the beginning of the webinar, you will have these slides available. So even though I'm kind of skimming through them rather quickly, you will have the opportunity to look at them, and the whole report of this particular study is available for reading and use as well. Present and opioid negative in the inpatient study, we show that there were significantly better outcomes with the buprenorphine patients. At the end of the study, at day 13 or 14, there were 59 patients that completed the study. 76.6% were negative at their last test. And in the clonidine, there were only 8 patients that completed the full 13-day process, and at only 22.2% completion rate. This is the same information in graph form. Give you an opportunity to look at that. It just states the information previously shown on that graph. So these are the demographics of the outpatients that were treated. And again, you can see there was a greater percentage of males in the program. The race is broken down there as percentage. Their ages, a little bit older. Employment was a little bit less, and education and number of years of usage was a little bit higher in this population. And the totals here were are listed here. So the outcome of the study shows again at the end of the study at 13 or 14 days, 46 of the initial 157 patients utilizing the buprenorphine naloxone program completed the program for a percentage of 29.3%. In the clonidine study, there were only 4 of the 74 patients in the outpatient program that completed the study, and for only 5.4%. Again, this is by graph, looking at the outcome of this in just a little different way to look at it. But you can see there was significantly better outcomes with the buprenorphine naloxone group than with the patients utilizing clonidine. So looking at the outcome too, for the number of patients that you need to treat in order to achieve a successful treatment outcome, for the buprenorphine patients it was 1.31 patients. For the clonidine patients it was 4.5. So the need to treat for clonidine versus buprenorphine in the inpatient program was significantly better outcomes, looking at it this way, as well as in the even more significant in the outpatient group, where the need to treat for the buprenorphine naloxone population is 3.4 to 18.5 for the clonidine population to achieve a treatment success. The protocol was designed to examine the use of Suboxone versus the use of clonidine in the short-term outcome in these settings. The results of the protocols then were pretty dramatic. The taper was successful in both outpatient and inpatient settings. The buprenorphine naloxone was superior to the clonidine in both settings. In the inpatient setting, 76% of the buprenorphine naloxone patients versus 22% of the clonidine patients were present and opioid clean at day 13. The outpatient setting, in the outpatient setting, 29% of the buprenorphine naloxone patients versus 5% of the clonidine patients were present and opioid clean at day 13. So if you want to utilize the buprenorphine program, what steps do you take to do that? And I'd like to just pause here. That was a lot of information and a lot of things that I just threw at you there that if you've taken some time to absorb and you'd like some questions, I'd be certainly glad to entertain any of those based on what we've talked about so far. I did want to so if you have some questions and you want to prepare those, please feel free to do that. And before we go on any farther, I just did want to mention too, as far as the formulation of the buprenorphine and the Suboxone and Subutex, there are some changes coming with that, in that the intent of the manufacturer of Suboxone and Subutex is to change from the tablet formulation to film strip formulation, which is going to provide significantly less problems with diversion to injectable use because of the nature of the strips which are used, and they're packaged individually, they're used sublingually, but in order to break them down and inject them takes a significantly greater effort on the part of somebody looking to divert them in that way. And there are other things being built into their manufacture to assist in addressing the problems of diversion of the drugs to others as well, and of dealing and of being able to follow a prescribed dose of that, even as it's packaged individually, every dose, to know where it was initially prescribed and who it was prescribed to, where the medication was filled at what pharmacy, and who the recipient of that medication was. So if they're found or diverted, there'd be able to be a history built right into the qualifier on each one of the doses of Suboxone that'll be provided in that manner. And there's been, there's also research being done about a patch applied, and there are patches available for treatment or utilization of buprenorphine for the treatment of pain management. And there's, I've heard talk of research of utilizing the medication in an injectable form that's longer acting in the body and has a dissipation in the body over time, so it can be utilized that way as well. So I think that the more we learn about the medication, the more we learn about its effectiveness and how it can be utilized with this population, the more we'll have the support of manufacturers and of trials to see what's the best and what's the most efficient and appropriate way to be utilizing the medication in this population. So,
I do have a couple questions if you'd like to go over those now.
I sure would. You bet.
Okay. Here's the first one. Some people seem to spend their lives taking methadone as a maintenance for the brain, allowing them to put their lives back in order, yet still give their brain a drug. Is buprenorphine a long-term or short-term use drug in best practice situations?
You know, it is both long-term and short-term, and it is in best practice situations utilized in many, many different ways. What we're talking about today is the withdrawal potential using buprenorphine and how effective it is in treating withdrawal on a short-term basis. But this medication can be used in long-term. It can be used over a longer, maybe not just for specifically for treatment of withdrawal, but for maintenance. It has been shown to be very effective as well, either in a shorter-term maintenance of a month to several months of utilizing the medication, and then when other supports and other treatment modalities and support systems are in place, the medication then can be tapered over a period of time and the medication discontinued at that time. But I've also seen it used appropriately and for longer-term effectiveness in some patients as well. So I think it has to be looked at individually and you know, very carefully monitored by the physician prescribing and by the treatment professionals providing support to that patient over time.
Okay, and then the other, what length of treatment or maintenance was recommended in the study?
This study is just specific for withdrawal. There are other studies about the utilization of buprenorphine and buprenorphine with naloxone in longer term, and that's contained in additional blending products that are available, and more in-depth study in the use of buprenorphine in the treatment of opioid dependence, and that information is available in those other trainings. But the information I'm presenting today in this webinar is specifically for the utilization of this medication in detox.
Okay, some more questions are just coming in. This is from the person who asked the first question. Is the issue of diversion abuse as great with this drug as it can be with methadone, or does the way it acts on the brain not lend itself to addiction?
Because of the ceiling effect with the partial agonist, and because buprenorphine is a partial agonist, it has less potential for problems with diversion. Not that it won't be diverted, but that it doesn't have the same appeal as the full agonist methadone does, and it doesn't have the potential for overdose that methadone has. So there are very positive things about this particular medication being utilized. Not that I mean that in certain populations this is going to be the medication of choice for the treatment of opioid dependence, although methadone in its utilization is very, very effective with many people in this population, as well as using clonidine in a period of time, tapering the clonidine through withdrawal, and then for the patient being drug-free too. So there is a I think it has to be highly individualized, but there is, I think, less potential for diversion and overdose potential with this drug because it is a partial agonist.
Okay. What are the stats after day 13? What are the continued abstinence after day 13? Are you recommending a follow-up with Suboxone maintenance or abstinence after day 13?
Well, that is part of the question that remains at the end of this study, is that you can see the effectiveness with withdrawal, and that there needs to be more research about what were there relapses after the successful withdrawal, which means that the patients who went through withdrawal at the end of the taper were stable. But then what supports were in place for them for ongoing recovery, and was ongoing use of buprenorphine appropriate in those patients, and in many patients it can be, and longer-term utilization of the medication can be a very positive thing with patients. And some patients may be, at the end of that taper and that the withdrawal process, perfectly stable at that point and advance into other areas of treatment and support and are able to remain abstinent from that point on.
Okay. One interesting note with the film Suboxone is that the film has started to be, it's an odd word, is that the film has started to be diverted to jails or prisons by placing the film behind a stamp so inmates can receive it through the mail and then lick the film off the envelope.
Well, there's a way always. It never fails to amaze me, the creativity that goes along with this illness, and I think of the thousands and thousands of patients that I've treated, and I'm still surprised every day by information like that and just how creative they can be in order to get the drug that they want into their system. And I'm sure each and every one of us could come up with many stories of just that kind of diversion or that kind of creativity used in order to maintain a drug habit. So it is, there will always be a step ahead of us. I think in there, the people that are using and the people that look to, the changes that we make, the research that we do, the wonderful products that we might have available to us will always be misused by a certain number of the population, and they'll always be the ones who get the most print and the most media coverage and that sort of thing. And I think we just need to keep one foot in front of the other as addiction treatment professionals and just do the best we can with what we have. And I recognize that those things are going to happen and those kinds of diversions are going to take place, and work in our own programs to do the best we can to prevent that or to recognize it and to work with patients who have a desire to change and a willingness to change and to follow and be compliant with treatment protocols. I mean, that's what we all wish in our patients. Sometimes you've got to, look at those patients that are, profess a certain amount of compliancy but are doing those sort of things. So we'll always deal with that. We've dealt with it with every other aspect of addiction services, and we certainly will with this medication.
Okay. Well, I have 3 more typed questions, and I do have somebody whose hand has been raised for quite a while for the phone. So how about if we take that, and then you can decide if you want to hold off on the other 3 and until the next break for Q&A.
Okay, that's great.
Let me see if this person was just playing with the icons or if he really has a question.
Okay.
Let's see. Terry Withrow, do you have a question? I unmuted your phone.
No, I hit it by accident, but thank you.
Okay, that's fine. No problem. Okay, so we'll do that. Do you want to go over the next 3 questions, or do you want to get on with your training?
Well, I think I could take the next 3 questions. I think the next aspect of training will bring up other questions too, but I'd be happy to entertain those. I'll try to keep my responses short, and then we'll move on, okay?
Okay. What is the meat of effective as moderate methadone? How do you define effective?
Could I hear that again? How would I define effective as far as what with methadone?
As far as moderate methadone, but I think that might be...
Oh, the question had to do with, I know what they're referring to, that looked at moderate doses of methadone was 60 milligrams in the study, 60 milligrams of methadone per day compared to the buprenorphine.
Okay, and then what are your stats after day 13 from the research stated?
There are none beyond this study. Those are the questions raised at the end of this study, but there was the idea with this study was to look at the research of patients utilizing this 13-day withdrawal to come up with the relapse rates. But I don't have that information to present today. But that is certainly the questions that are asked at the end of this particular study. And I'm sorry I don't have the research to speak to what happened after this taper. You know, and maybe that is a matter of sharing information with other people who are providing the buprenorphine and have utilized this withdrawal protocol and are able to speak to that too. So I'm sorry I don't have the specifics for that.
Okay. This is our team was excited to hear of a 13-day detox. We are finding frustration with the long-term maintenance and would like protocols for short-term detox.
And that's what we're discussing in our next segment, is just how you do that, how you induct, how you determine which patients are appropriate, and how you induct them on the buprenorphine and utilize a reduction, a taper over the next 13 days to get people safely off the opiates and completely off the buprenorphine. So this is and the next segment of my presentation is specifically about that. So hopefully if you have additional questions about that, we can answer them as we go along. But I'd like to continue now. Is that okay, Chris?
Yes.
Okay.
Thank you.
Mm-hmm. So I'm just going to move along here. I've got to, you know, catch up with my mouth here, and we'll move along. So the first thing in determining if a patient is appropriate for this 13-day taper is to look at the patient and whether or not they're appropriate for buprenorphine treatment. The screening assessment that were used in the CTN protocols was looking at the medical history, looking at the history of prior medication use, looking at psychiatric evaluation. They utilized the DSM-4, of course, checklist for substance dependence, so they're certain that there was a diagnosis of opioid dependence, looking at HIV risk, and also looking at hepatitis B and hepatitis C serology tests. The safety assessment that was also used in the clinical trial protocols was to do a complete physical exam, vital signs, a blood chemistry, hematology, a urinalysis, an ECG, and a pregnancy test. With the patients who had as this module apparently, as it was developed, these were the factors that were looked at in determining whether someone would be safe to utilize the medication. The use of buprenorphine in pregnancy is also a frequently asked question, and currently the FDA recommendation is for methadone, and yet this medication has been utilized, I know of, and talking with other professionals too, in pregnant women who are opiate dependent. And there are studies ongoing and have been studies in the past about utilizing this medication for pregnancy as well. But currently the recommendation is for the use of methadone, because methadone's been around a very long time. It's been studied extensively in the use of pregnancy, and so that is a question that is frequently asked. In this particular study, pregnant females were excluded from the study. So once you determine that buprenorphine is the best treatment, the next step is induction. And the things that we look for in induction and transferring patients who are on opiates onto buprenorphine is that there are 3 ways that you know, as you're inducting people onto this medication, that they could still experience significant withdrawal. And so there are aspects to really be alert to and careful of in doing that. Is the dose too low? if the dose is too low with buprenorphine with patients, they get insufficient agonistic effects, and they have so many breakthrough symptoms, and that the medication is not effective in treating the withdrawal symptoms. So the dosage has to be moderated according to that, and there is a specific taper that we'll talk about as we go along, but there have been, in some cases, adjustment in the medication dosage for patients who are experiencing, insufficient relief of symptoms. So some patients may be taking, if you start out at the dosage level recommended here and they have been on a maintenance level of opiates that it's much higher in the agonist level, this dosage level may not reduce the amount of withdrawal symptoms sufficiently. And if a patient is a full agonist user, methadone, heroin, whatever, the partial agonist may not fully replace that, so there may be some withdrawal symptoms, breakthrough symptoms that occur as a result of that. And if they have a much higher level, the ceiling effect of buprenorphine, if they need a higher level to achieve that maintenance, that ceiling effect of buprenorphine may result in withdrawal as well. And there are chances, too, with buprenorphine, as you induct a patient onto it, that it could precipitate withdrawal if there is opiate on the receptor sites and the patients you are inducting have considerable amount of drug still in their system, then the buprenorphine will kick off the other opiates off through the receptor sites, causing significant withdrawal symptoms. So those are the aspects to be concerned about as far as the level of opiate in the system as you are inducting a patient onto buprenorphine. Buprenorphine is administered sublingually. This is an 8 milligram dose of Suboxone. It is light orange. It is flavored with kind of a lemon-lime flavoring and a sweetener. This is done to overcome sometimes, it is a very bitter tasting medication, and the bitterness of the tablet is they try to modify that some by adding this kind of citrusy taste. And the orange color has been added to ensure a clear differentiation between Subutex, which is a plain white tablet, and Suboxone, which is this orange in color tablet. So in the 5 steps to starting this buprenorphine naloxone induction is to have the patient abstain or impose an 8-hour interval between the prior agonist use, whatever they're using, whether that's heroin or one of the prescription agonists, whatever it might be, and the buprenorphine administration. So we want them to abstain and have an 8-hour interval from their last dose to when we initiate the buprenorphine. It is much more optimal with the patient, of course, to have mild symptoms occurring. You don't need to have a patient in full-blown, miserable withdrawal to initiate the buprenorphine, but it is better for them to have the opiates out of their system to the point they are experiencing some mild withdrawal, because when you initiate the buprenorphine, the withdrawal symptoms are going to be managed. The patient is going to feel the effect of the medication immediately and feel better immediately. We'll feel those effects of the medication. We also want to verify that the urine sample is methadone negative. Methadone stays on the receptor sites and has a stronger affinity over a longer period of time and a longer half-life in the body, so that if you induct a patient on buprenorphine who still has methadone in their system, they will get really sick. That is just the nature of the transfer of the bup from methadone. And then you select an appropriate substitution dose based on the history of the patient, and you start with the lowest dose that you can to alleviate the symptoms and increase it over a period of several days. This is the dosing schedule that was used in the clinical trial networks. Day 1, the patient was, as I said earlier, in mild withdrawal, 8 hours from their last dose of their agonist, whatever they were using, and they were given a split dose of Suboxone. So they were given 4 or a half dose of the 8.2 milligram Suboxone tablet sublingually under the observation of the nurse or the staff in the program, the physician or their staff in the program, and the tablet takes about 2 to 10 minutes to dissolve under the tongue. You put it under sublingually. They waited for a period of time, and for the first couple of hours after the first dose of medication, they were carefully monitored. Their withdrawal symptoms were assessed using the COW scale, the Clinical Opiate Withdrawal Scale, to see whether or not they were responding to the buprenorphine appropriately, whether or not their withdrawal symptoms were improved with the dose, and whether or not they tolerated the medication well. The dose was then split. They were given another dose. If they tolerated that 1 milligram dose, they were given the rest of that particular dose of medication on day 1 within, between 8 and 12 hours after the initial dose, after they had tolerated it appropriately. Day 2, they were given a tablet, a full tablet, in 1 dose of buprenorphine and naloxone, 8.2 milligrams. On day 3, they were given 2 tablets, 16 milligrams of the buprenorphine with 4 milligrams of naloxone. And this is the tapering schedule that was used. As I mentioned, day 1 was a split dose to see how they tolerated the medication. Day 2, a full dose. Day 3, which is usually the most significant for withdrawal medication or withdrawal symptoms, usually peak at day 3 or day 4. So the peak of the medication is gradually increased to that 16 milligram dose and then decreased over the next days in the taper. So the taper then occurs from day 4 down to 14 milligrams, day 5 to 12, day 6 to 10 milligrams, day 7 they're down then to 8 milligrams of the buprenorphine and naloxone tablet. 8 and 9 they stay at 6. Day 10 and 11 they're at 4 milligrams, and day 12 they're at 2 milligrams. So the peak symptoms are treated with the highest doses of the buprenorphine and then a gradual taper over that 13 days. The study was successful, and we know that, but will it work for everyone? Well, as we know about treatment services is that there isn't one program that's going to work successfully for everyone. And this taper is a suggestion of use and was utilized in this clinical trial, and we can look at its effectiveness. And we also need to look at whether or not it's appropriate for certain patients. This was the inclusion criteria for the clinical trial protocols. Treatment-seeking males and non-pregnant, non-lactating females 15 and older were included in the trial. They met the DSM-4 criteria for opioid dependence and were in need of a medical assistance for opioid withdrawal. Their systolic blood pressure was equal to or greater than 100 millimeters per, and their pulse 56 beats per minute, greater or equal to that. They were in good general health, the patients that were treated in this clinical trial program, and in case of any medical or psychiatric conditions need ongoing treatment, they were under the care of a physician or willing to continue the patient's medical management and cooperate with the study physicians who are prescribing the buprenorphine. So they enlisted the support of the patient's own physicians or providers in this study if they did have medical or psychiatric needs. They were agreeable to and capable of signing the informed consent approved by the Institutional Review Board, and if they were under the age of 18, excluding emancipated minors, assent and concurrent consent from a parent or legal guardian was necessary. Use of one of the following acceptable methods of birth control by female patients of childbearing potential were included in the female patients in this trial. They have to use an oral contraceptive or a barrier method, an intrauterine device, an implant, the contraceptive injection, or abstinence completely from sexual intercourse. Exclusion criteria for the patients used in this study were medical conditions that prevented appropriate use of medication, which included, for this study, active hepatitis or an unstable cardiovascular disease or liver disease or kidney disease. Clinical significant abnormalities in their ECG. If they were allergic, of course, or sensitive to buprenorphine, naloxone, or clonidine, they were excluded. If they were receiving medications which would adversely impact or adversely affect the clonidine usage, if they were on other, for instance, calcium channel blockers, digitalis, or beta blockers. If they had acute severe psychiatric conditions or were an imminent suicidal risk, they were excluded from the protocol as well. If there was a dependence on alcohol, benzodiazepines, or other depressants or stimulants that required immediate medical attention, they were excluded as well. So if they were a population utilizing other drugs or alcohol and their withdrawal was complicated by those substances, they were excluded. Participation in other investigational studies within the last 30 days, they were excluded, so there wasn't a compounding of reported symptoms or whatever. If they had been included in another investigation, they were just excluded. And if they had been on methadone or LAM maintenance for detoxification within the 30 days of induction. Pregnant, lactating, or planning to become pregnant females were excluded, and those were the stipulations that were drawn from the Clinical Trial Network throughout all of the sites that participated in the study. The other consideration for these patients were ancillary medications that were used to treat withdrawal symptoms, because the patients in the study all had, or many of them had, additional physical symptoms that plagued them despite the induction onto the buprenorphine, which stabilized many of the acute symptoms, but the more protracted symptoms continued to cause concerns. So there was a consensus among the Clinical Trial Network sites to utilize specific types of ancillary medications for specific complaints that the patients had. So these were the ones that were used in this trial. There should be a consideration, of course, given to sites that use this taper and what sort of ancillary medications would be utilized by each site during and it may vary from site to site or group to group as far as what you're willing to utilize for patients who are experiencing ongoing withdrawal symptoms. But this is a list of the medications that were utilized. Some physicians weren't required to use these medications, but they came together as far as what they would use in these circumstances. The use of ancillary medications was fairly common during the medically assisted withdrawal. And if you've worked with opiate-addicted patients, you know that they are so very focused on somatic complaints, and every subtle nuance or change that occurs in their body, they just seem to have a hypersensitivity to, and just this awareness, and it's like their body coming alive again, and it's been so subdued, all of the symptoms with the agonists that they've been taking, that they just don't feel the things that all of us feel on kind of a day-to-day basis. And so they're just hypersensitive to that as they're in withdrawal. And so many of the symptoms that were reported were related to those particular nuances that occur with opiate withdrawal. Dispensing of medication at the physician's discretion in accordance with the clinical need. That was all of the decisions in regards to utilizing the medication, of course, was left up to the physician dealing with these particular patients. And the choice of medications that were going to be used in the trial were limited, and most patients received at least one ancillary medication during the study. So these are the medications that were used. It's not clear what effect it will have if different medications are used, as I said, in utilizing this taper for the patients in your practices or that you're working with. But for complaints of bone pain or arthralgias or muscle aches and pains, which is probably one of the most common symptoms, or kind of muscle twitching and aching, acetaminophen, ibuprofen, or Robaxin were the three choices. For patients complaining of diarrhea, again, a very common symptom in withdrawal. Most patients who are on opiates suffer more problems with constipation, and so the withdrawal potential, of course, includes diarrhea, which is the opposite of what they've been dealing with, is they're detoxing from the opiates. So Imodium was utilized as well as Donatol. For anxiety and restlessness, the choices were lorazepam, and Cirax, which is another one of the benzodiazepines, which are contraindicated in the use of buprenorphine. That is one of the hallmarks of utilizing buprenorphine is the potential for problems in mixing the benzodiazepines and buprenorphine, but they were approved in this study for use of anxiety and restlessness. Also, phenobarbital and hydroxyzine or Atarax Vistaril was also listed as the utilization of ancillary medications. For nausea, Tigan was used. For insomnia, Benadryl, Ambien, Deseril or Trazodone, and Sinequan or Doxepin were used in the clinical trials. Of the ancillary medications used among the patients receiving buprenorphine, 19.7% of patients received no ancillary medications, none at all. But 80.3% received at least one. And you can see the most common complaints were insomnia, the bone pain and arthralgias, anxiety and restlessness, nausea, and diarrhea. The average of 2.3 withdrawal symptoms were treated in this clinical trial. This is just a graph of the study day where the patients complained of the symptoms, and they gradually decreased over time as the withdrawal symptoms just decreased over the 13-day study. You can see that there was less utilization of medication over time, but the peak seems to be in the 3 to 4 day area there. Adverse events are reported as far as in any study. You look at reported additional symptoms or problems that occurred during the taper, and these are defined in any research protocol as adverse events. Information about these adverse events were collected from all the medically related research studies and were defined as any untoward medical or psychiatric occurrence that or psychiatric occurrence during the patient's participation in the trial. Adverse events may or may not have been related to the treatment being provided, but by collecting the adverse information, we can collect data concerning the side effects and what occurred during treatment. Adverse events were addressed or assessed daily during detoxification, and again at the one-month follow-up visit. They were done by utilizing again the COWS assessment and seeing whether or not patients were experiencing additional withdrawal symptoms, and there was an adjective rating, the adjective rating scale for withdrawal, or the ARSW, and the visual analog report. Those were the instruments that were used in asking the patients to look at the symptoms of withdrawal and whether they were still experiencing them how they were, improvement, and giving them a rating scale. Differences were seen across the group as far as the number of adverse events reported. In the inpatient study, whoops, there's the wrong thing there. On the inpatient study, the significant differences were seen in the sample, but not for those completing the taper. The differences in the outpatient study were kind of impossible to compare, really, to the relative number of adverse events reported in the inpatient study compared to the outpatient study. But it's likely the larger numbers were seen in the inpatient group because by the virtual fact that they were in a 24-hour facility being monitored on a 24-hour basis, unlike the outpatients who were seen only in the clinic and only at intervals in the daily intervals in the clinic, and didn't have the 24-hour monitoring. But 18 side effects showed up in the program, and the safety profile was excellent in this study. 18 individuals experienced serious side effects over the course of the clinical trial, and they included 61% associated with hospitalization for drug relapse or for similarly related treatment. There were 83% transpired during the follow-up period, the adverse events reported. There was a death reported in the buprenorphine condition that was secondary to a respiratory failure that was a result of a myocardial infarction. It was unexpected, discovered in the 6-month evaluation segment, and it was associated with a heart attack that occurred 4 months after the patient was had completed the taper from the buprenorphine, and it was not buprenorphine naloxone related, but was within the clinical trial follow-up study within that 6-month period. And there was only one event in the Clonidine study resulting from a death that resulted from bacterial endocarditis, and one event of hematemesis, which is bloody vomiting, that was presumably due to bleeding in an esophageal tear on a patient who was on the Suboxone. And the patient had excessive hiccuping, which resulted in the esophageal tear, and that was it wasn't a death as a result of that, but that was one event reported while the patient was on the buprenorphine. So the role of psychosocial treatment during medically assisted opioid withdrawal is important to consider in this as well. The study was conducted using different clinical trial sites, both inpatient and outpatient. There were the participants were provided some counseling, and the outcome of this study looked at the difference between patients who had counseling involved in the curriculum of utilizing the buprenorphine for treatment of withdrawal and those who weren't. Counseling is essential, is the important take-home information from this, is that without that, with just medication and not a supportive environment or education or other psychosocial support systems, there is less chance of a positive outcome. Medication and therapy is really needed to maximize the therapeutic effects. And they used a patient handbook and each site did that in their curriculum, gave a patient handbook about addiction, about the process of withdrawal, educational kinds of materials and that sort of thing that were utilized, and that really spoke well for the treatment programs involved in the clinical trial network, utilizing that type of information and support in order to affect a ongoing support for these patients in this trial. Key lessons that we learned from the clinical trial experience then is that first, direct induction with buprenorphine is acceptable to the majority of opioid users. 90% of the patients that completed the induction reaching a target dose of 16 milligrams within 3 days. 90% of those patients completed that and reached that target dose. A substantial number of patients completed the short-term detox, regardless of the treatment setting or program philosophy. This program thus met a major goal of many programs to improve the early treatment engagement. And that is hopefully what this 13-day taper, this short-term treatment, can help us establish a very effective therapeutic alliance with local care providers. So if a physician utilizes this taper in a clinically based practice, they are in a very healthy alliance with the local providers that can provide the treatment services and support necessary to see people through this short-term withdrawal. Ancillary medications were provided to a majority of patients taking the buprenorphine naloxone, but mostly for protracted withdrawal symptoms that we see so commonly with patients withdrawing from opioids. And I think if you address that and do some good education with patients as they're coming off the opioids, they know that not every symptom or every physical ache or pain that they're going to experience is going to be managed with the buprenorphine naloxone program or the Clonidine program or whatever utilization we have as far as treatment of withdrawal. There is going to be some discomfort and some change in status and some physical symptoms that are just going to need to be addressed individually and over a period of time with patients. And how we utilize medications and how we see people through this initial withdrawal is a very important aspect of getting people into an appropriate treatment process. Buprenorphine naloxone is safe for the use in a wide range of community settings. There were very few serious adverse events, and most of them were not related to buprenorphine naloxone. Patients' interest in the buprenorphine naloxone detox was very high in these programs, and many of the programs developed a waiting list suggesting that the combination mixture will not deter patients from seeking buprenorphine treatment. I think those of us who work in the program, in our state, for instance, we don't have a lot of physicians that have taken up the support of buprenorphine treatment, and they are scattered throughout a state that is, where patients have to travel great distances in order to see physicians willing to prescribe this medication and to monitor it. And sometimes it causes a significant amount of issues in ongoing utilization of this medication. We're treating a patient with a detox with this medication because it is of its availability. So we find, as did many of these programs, a waiting list developing and patients having to continue to use until they can get into a program where they can have buprenorphine, they can be assessed for that and utilized appropriately. All sites expected patients to attend counseling regularly. Whether they were a short-term buprenorphine detox would fare better as well in primary care office-based settings where services are not on-site, and whether or not this would work in a setting like that is not really known from this study. But physicians can use this product and can use a taper like this in their clinical practice, and whether just knowing the history of opiate treatment, and even based on this study and on discussion with many other professionals, we know that there is just much better outcome when you can combine good medical practice and treatment of withdrawal with buprenorphine and really good treatment philosophy and support as well. medication was the best predictor of treatment outcome for opioid medically assisted withdrawal, regardless of the treatment setting. So medication-assisted therapy was the best predictor of the outcome. Inpatient treatment was the strong predictor of treatment success, and and my dream is that every patient that we treat for opioid dependence, we'd be able to bring them into a safe environment with medical personnel, in a supportive environment with other patients who have experienced opioid withdrawal and have utilized buprenorphine, and can provide support to patients experiencing this early in their recovery. And that we know that sometimes that would be the most ideal environment, but we also know that that can provide us sometimes with the best outcomes, but not always is that available to us. So we have to look to what supportive efforts we can make in our outpatients as well, and utilizing this in a successful outpatient approach as well. Those with greater reduction in opioid withdrawal severity from baseline to day 3 were most likely to have a positive treatment outcome. So, if they know what withdrawal feels like, and they know that it is being managed, and that they have a reduction in the symptoms from when the medication was inducted to the day 3, they have a much more positive outcome in treatment. Those who did the best with Clonidine had low severity withdrawal symptoms at the baseline. So Clonidine can still be a very effective tool in treating withdrawal from opioids. It is a matter of carefully screening patients and knowing what is going to be the most effective and the best approach to treatment needs. And patients who are looking for abstinence, are concerned about the use of a partial agonist like buprenorphine, Clonidine and support can be a very valuable tool in working with them as well. Lessons from a study of longer and shorter tapering schedules. We can look at the difference in some studies that have looked at that. Ling is a researcher that has, and colleagues of his that have conducted a follow-up trial with these participants not these participants, with participants who had used a taper and were stabilized for a period of 4 weeks and then randomized to a 7 or 28-day taper. So this was a different study, but what they learned from that study is that a relatively quick taper may be advantageous and did not result in relapse to drug use at a greater rate than longer tapers. And that patients stabilized physiologically on a range of buprenorphine doses that can be tapered successfully over a period of 7 days. So a longer taper of 4 weeks was tried, and a shorter taper over 7 days that can be stabilized. So the magic isn't in the day 13 or the 13-day taper, but can be adjusted to fit the needs of the patient depending on the response that you're getting and what their assessments are looking like. But there was no advantage to prolonging the tapering schedule for several weeks either. So a quick taper or a longer taper or a 13-day taper, it's really highly individualized and dependent on the patient that you're treating. So the additional research, as we've talked about already, that needs to be done with this is to answer questions such as, to what degree do these patients return to opiate use following the taper? How can we study that? How do we do the follow-up with the patients that we do this taper on? Are we engaging them in treatment services, or do we do the detoxification? That's the last that we see of them. How do we engage them in follow-up to determine what is the best and whether or not and how effective this detox is? What counseling is best coupled with this taper? Is individual work appropriate? Is a support group of other buprenorphine patients appropriate? Is a level of care based on ASAM criteria for intensive outpatient or partial hospitalization or residential or inpatient required based on the ASAM criteria? And so what counseling really is best? Motivational interviewing techniques and but what works best with this particular population? The good questions to be asked, and of people utilizing it and finding success with it. Sharing that information with other providers is so important. What difference would it make if the treatment were provided in a physician's office rather than a substance abuse treatment program or clinic where other ancillary services are available? As we saw from this study, whether it was the inpatients or the outpatients, they were all connected to an established treatment program. So if a physician is doing this taper from his office, what other ancillary services need to be available to patients doing that? And what support can we offer physicians who are utilizing this medication in that way? So that is the research questions that came from this study, and I'm sure that many of you listening to this presentation this afternoon are thinking of others as well. And I would certainly now entertain additional questions that you might have or comments that you'd like to make in regards to the information presented here today.
Okay, I do have some more questions that have come in.
Great.
I'm hearing from patients that buprenorphine has profound effects on motivation and mood, making it extremely hard to get off once they get started. They say this is different than other opiates. What do you know about this?
I've heard that same kind of thing from patients as they are, as they talk about, patients who are on maintenance doses of buprenorphine or Suboxone therapy that I've worked with too. I've heard similar concerns in that way, and that we have found that as we taper patients who are on more of a maintenance dosage or level or utilization of buprenorphine, that they have to have in place other support systems and other strategies to deal with the concern that they have as they are coming off the buprenorphine, and that the taper has to be slow, the taper has to be supportive, and that it involves a lot of really good talk therapy and support from other patients who have experienced those taper and discontinue kinds of concerns. They are worried about withdrawal, and yet as you do a taper over a period of time, the symptoms can be managed with the support of and the ancillary services provided to the patient. But that is a significant concern that I've heard from patients as well.
Okay. Before we go any farther here, because I do have other questions, I just have a little ad. And the IRETA website, and I'll be sending everybody a link to it after this session. We did do a 3-part webinar recently on buprenorphine treatment, a training for multidisciplinary addiction professionals. So this is 6 hours done over 3 2-hour webinars. And as with this one, those were recorded too and are available for viewing whenever they want. Just they can just click on the part they want, and the PowerPoints are also available. So that's the plug.
That's great, Chris, that's available, and that is a wonderful training and has significantly more information about the utilization of this medication and using the medication over a longer period of time and using it in a maintenance kind of formulation with other treatment support. So that is a well worth the time and effort it takes to view that and be a part of that kind of training as well.
Yeah, right. And it might answer a lot of their questions too.
It will. Mm-hmm.
What control precautions have been put in place for medication administration to prevent selling buprenorphine on the street?
Well, I think it really varies from physician to physician. I can speak to what we do. We give very small prescriptions of buprenorphine. Our patients never get more than a 2-week supply at any time. Our patients who are, into longer-term maintenance or that sort of thing. So, there are lots of precautions that can be taken in the amounts that are prescribed, in utilizing prescriptions that can't be altered, in having the patient locked into a particular pharmacy and not being able to fill the prescription anywhere but in that pharmacy, and having so there are lots of ways that you can do that to prevent that kind of diversion. But another thing that we do is urine drug testing to determine the level of buprenorphine in our patient's urine, as well as the metabolite norbuprenorphine, so we can see whether they are taking it regularly and whether or not they are taking it in the therapeutic range.
Okay. I have two questions from one attendee. What are the advantages of combined buprenorphine with naltrexone over buprenorphine alone in short-term and long-term treatment and studies? I mean the role of naltrexone, or naloxone with this pharmacological ratio that is 4:1. Do you need me to repeat that?
No, I think I know what the intent of the question is, that what is the advantage of using Suboxone? And that is primarily to prevent diversion, to prevent misuse and diversion with it. And I think it's important that we support the combination of the Suboxone and naloxone. Plain buprenorphine can be easily diverted, or more easily diverted, and utilized in injectable form. And as I mentioned before, our patient population and the lifestyle that they lead, the people that they associate with, puts them at greater risk for having their medications diverted, or that they are sharing them with others, or that they are inclined to, when they are stressed or whatever, to use the oral medication in an injectable form in order to get high from it. So the Suboxone is in the formulation only to provide that less diversion is possible with that medication, and I fully support that. And it's there are patients that complain about the combination formulation making them sick to their stomach, or they get nauseated, or they have headaches, or they want people are specifically looking for just the buprenorphine in that formulation. It gives me pause to wonder why. Other than the minor complaints that they might have. And with adjustment of dosage and adjustment of time of dosage, that very often, those minor symptoms that they complain about with the combination product dissipate, and they disappear. So it can be managed. But the formulation, the Buprenex, buprenorphine, the only time that we utilize that is when we have a patient who still has a positive urine drug screen for other opiates. And if you give the antagonist, the naloxone, we see that they develop much more significant withdrawal symptoms. So sometimes we have inducted patients on just buprenorphine, but it's only patients who are in the residential program. It isn't something that we would send them out with, because then the chances for diversion are even greater.
Okay. What are the effects if the patient will abuse opioid along with buprenorphine? I mean, if the patient is doing so without informing the care providers, what are the things a medical provider will look for during the follow-up, or any side effects or after effects when used with opioid in outpatient setup?
Well, we do drug testing. We do very frequent drug testing, and we look for the presence of all the opiates in the urine drug screen. We also look for drugs of abuse and alcohol. We do an ETG and ETS as well. But I think that is an important aspect of any program, is to do some randomized drug testing with the patients to determine if they are staying abstinent. Other things, of course, you look for is the signs of intoxication of opiate, on a patient that's presenting in the clinic or in the outpatient setting. And other behavior changes that occur as well: non-compliance, not showing up for appointments on time, calling and asking for a refill before it's intended, or that it's before it's expected. Loss of the medications with lame stories, but just a change in behavior and the change in the level of compliance and the change in engagement with the people who are working with that patient. I mean, you get clues. If you know your patients, you get clues when you know they're slipping and when you know that they are out of the compliance that they were in, or in the that they're drug seeking maybe for other people in their life that are in need of the medication, or they're seeking the medication in order to sell it or divert it to supplement their own income or their own lifestyle, or they may be using other drugs and not using opiates any longer, but are selling it to get the drugs that they're after. So there are clues and things that we need to look for in just the patient's presentation and behavior and their compliance and their outcome of their drug screens.
Okay. What are the effects on people who are prescribed buprenorphine and clonidine?
I've seen them used in combination, and the clonidine can be effective in reducing some of those protracted symptoms of withdrawal, block some of the diarrhea and the muscle aching and that sort of thing. So, and also one of the major concerns with insomnia, that sometimes clonidine has that its effect, one of its side effects is drowsiness, and sometimes clonidine, seen utilized at bedtime, can reduce some of those restless leg, insomnia kinds of things when utilized in combination with buprenorphine too. I've seen that utilized in that way.
Is the patient handbook that was used in the clinical trial available to treatment providers who may be considering implementing deep detox in their program?
One of the handbooks that were used, and it is available, is called Opioid Dependence Handbook for Recovery Using Buprenorphine, and it was written by Dr. Walter Ling. So that is a resource, and other programs, I believe, in the trial use their own handbooks or devise their own handbooks for utilization in the program. But that was one that was given to the patients in these clinical trials, was Dr. Ling's book.
Okay. If you can email me with that full title and author, I will forward that on to all the attendees so they have
Great.
that.
Sure, I'd be glad to.
Okay, and then here's one last question. So far it's the last question. Are some substance users utilizing this drug so that they can reduce the amount of drugs which they need to get high?
I think that that's the case, that there are, misuses and there are all kinds of experiments going on with this medication of the users of it, and the people that misuse it in that way. So I've heard of all different kinds of ways that people have tried to inject over its effects, and that there are, as I said, always going to be people that use it in a way that it wasn't intended to be used, and gives the use of it in legitimate treatment programs or in clinical sites and physicians using it that cause so much frustration and give you such a big black eye when you hear about how people are using it. When I've seen it work in such positive ways in context with treatment, and you think that those kinds of situations sometimes detract from the positive aspects of this medication, that there are patients who use it appropriately and find recovery with its use in a way that I've not ever been able to see in many patients that I've dealt with. I think of the years that we didn't even have clonidine. As I've been in the field a long time, that we didn't have clonidine to use, and what a relief it was to see that. And now to see buprenorphine and to see how it works and how wonderfully it works for patients who have the drive and the will and the support to make changes in their life. It's miraculous to see how this can work. So I'm hoping that we can maintain a a profile of positive outcomes, and not ignore negative outcomes in research, but not just play up the the ain't it awful kinds of things that we hear about this medication too.
Okay, well, I don't have any more questions. If people do have some more, please get them into us right now. We do have another 10 minutes before the webinar is officially over. I'm going to switch this back just to my my screen here so that we have that to finish off. But again, please let me know if you have any more questions here. And I will be following this up either this afternoon or tomorrow morning with an email that will include the PowerPoints. It will include an online survey, which is very quick, and we hope that everybody participates in that. It'll also include a certificate of attendance and a CEU order form for people who need those. This is being recorded and should be on our website before the beginning of next week, and you'll be able to view this again just by clicking on the link. You'll also have the PowerPoints available there as well. It just will not, be good for CEUs. We have not gotten CEUs approved for the recorded session.
Marvis,
So,
this is, oops, I'm sorry, Christina. Marvis, this is Candace. I just wanted to thank you for your presentation today, but more importantly for the knowledge and the work that you're doing in Bismarck, North Dakota for the people who are suffering there with opioid dependence. I can tell your passion for helping this group of persons that are in such great need and the positive effects that you're seeing on a daily basis in the use of buprenorphine as a medication for treating opioid dependence. So thank you so much for taking the time to be able to join us today and present this information for everything you're doing there in Bismarck.
Well, thank you, Candace.
Yes, and once again, thanks so much for stepping in at the last minute. We really did not want to have to cancel or postpone this webinar when we had so many people registered for it.
Well, I was glad to do it. Thank you.
Okay, well, at this time, we're going to close this webinar, and thank you all for attending and for your participation.